Okay, hi everybody. Okay, it's great to see so many familiar faces. Raise your hand if you know me personally. A couple, okay. All right, well, hi. I'm going to talk about clinical trials and future treatments, and to do so, I'm going to talk about the disease itself to set the stage for how I think about what we need to do to get really good treatments to improve care for this disease. These days, we tend to show this kind of list. I've worked with almost all the companies that are making the products that I will show you, except for the very last one. And here we go. So what do I think we need to do to improve care in this disease? Well, I think the first thing is we need to improve our diagnostic accuracy. I think we need to improve our ability to control movement or motor features. I think we need to improve our ability to improve or control non-motor features. We definitely need to improve what happens long-term as people develop more and more disability over time. And this, I think, entails two things. We need to be able to diagnose the disease earlier, and we need to be able to slow progression. And most importantly, we need a cure. So how are we going to get there? Well, here's what they taught me when I was in medical school 30 years ago. Boy, I wish I knew how to get this pointer going, but I don't. All right. So I think most of you can see over here. And what they showed me in medical school was in Parkinson's disease, people are losing these neurons, the dopamine neurons, here depicted in red. And once an individual has lost about 50% of those dopamine neurons, and dopamine in the brain is reduced 50%, people get the motor signs of Parkinson's disease: slowness, stiffness, and tremor. And then if one took the brain and sliced it, and I think you saw this morning, a normal brain looks like this. You see this dark stuff. What's that called? What's it called? Substantia nigra, which means dark substance, and that's normal on the left. And if you lose that dark substance, you have Parkinson's disease, because that dark substance is a marker of dopamine neurons. What is the dark stuff? Oh, I thought somebody knew what they were talking about. It's Dr. Sanchez-Ramos over there answering the question. That's great. Very good, Juan. Okay. Okay, so it's melanin. Melanin, just like the skin in your skin, that's in those same neurons that make dopamine. So here's somebody, this person's lost basically all of the dopamine neurons, and that person has Parkinson's disease. Now, the other thing that you see is this. In some of these remaining dopamine neurons, you see these aggregates of protein called, who knows what? Lewy bodies, exactly right, Lewy bodies. And so this has been known for many, many years. Again, they taught me that in medical school. We didn't know what they were, but if you see that, that's a good sign that you're dealing with Parkinson's disease. In addition, they said, well, how do you recognize Parkinson's disease? They say you look for 2 out of 3 things: bradykinesia, which means slow movement; rigidity, which means stiffness; tremor with the limb at rest. I think you went over all this morning. In addition, Parkinson's disease tends to start on one side, and when you put patients on dopamine medications, they tend to improve. And that's what they taught us. Well, it turns out we now know that when I do a study and look for patients who fit those criteria in early Parkinson's disease and put them in a clinical study, what % of the time do you think I'm wrong? I guess we shouldn't say me. What % of the time do you think experts are wrong? 12%. That's a very good guess. Somewhere 10 to 15%. Not 50%. No, that would be bad. It'd be really hard to test medications if it were 50%. But 10 to 15%. And how do we know that? Because we now have brain scans that help us assess the dopamine system in the brain. And I worked with GE, which is the company that now manufactures this scan, and it's now available, called DAT scan, and it's helped us confirm whether patient's dopamine system is normal or not. Now remember what I just said, it helps identify loss of dopamine neurons. It doesn't really say Parkinson's disease or not Parkinson's disease, because there are other things or other diseases in which people lose dopamine neurons, specifically what are called atypical Parkinsonisms, multiple system atrophy, and progressive supranuclear palsy. Does anybody here have MSA or PSP? Got one down here. Okay. But there are other things that I call the cousins of Parkinson's disease. Those diseases, too, those individuals are losing dopamine neurons. So if a doctor were to say, oh, we'll get this scan, and if the dopamine is down, that's Parkinson's disease, no, that's not right. But on the other hand, once somebody has slowness and stiffness, we expect the dopamine to be low if, in fact, the diagnosis is Parkinson's disease. So let me just show you how this works. If we take a big, long dopamine neuron all the way down the hall here, at the very tip of the dopamine neuron, there are these little dopamine receptors. When somebody gets the scan, they get an injection of material called DAT scan that goes in the blood. It travels up to the brain, and it connects and sits right on these dopamine transporters. You get a fancy scan. You can actually see the scan on here. Again, I think you saw this morning. And if there's a normal amount of this DAT scan sitting on the end of dopamine neurons, you see these nice two big fat commas, we say. But if people are losing their dopamine neurons, look from the back forward, this person has lost a good number of dopamine neurons coming from that room up to this room. And then here, look, the commas have lost their tail, and now we say they're periods or dots. So this person has lost a lot of dopamine neurons, and so that person has lost dopamine neurons. It could be Parkinson's disease or one of the cousins of Parkinson's disease. So that's how we know in studies, if we look at patients who go into studies in early Parkinson's disease, about 10 to 15% of patients have a normal scan. Those individuals, we know, do not have Parkinson's disease. So we now have these scans available in the community. Not everybody needs a scan like this. If I see a person who has obvious Parkinson's disease, slowness, stiffness, rest tremor, they respond to dopamine medication, they don't need a scan. Why? I know what they've got. They've got Parkinson's disease. But suppose it's a confusing case, or they don't respond the way I think they should to medication. That's the kind of case I'm thinking, if there's confusion or uncertainty, those individuals, it may help us think about the case by getting this kind of scan. Make sense? All right. Now, over the 30 years since I've been in medical school, the view of Parkinson's disease has changed dramatically. And how did we get there? Well, I think this is one of the real initial steps in how we got there. This is a family from Contorsi, Italy, where in that family, about 70 individuals out of about 170 had Parkinson's disease. Strange, right? Usually, if I see a person with Parkinson's disease, they'll say, well, maybe an aunt had Parkinson's disease or somebody, a distant relative. That's not too unusual because Parkinson's disease is so uncommon. But this is very unusual. Clearly, this family has Parkinson's disease. So what do you think is the basis of their Parkinson's disease? Yeah, hereditary genetics. It's in the genes. So this family was discovered, and it took many years until there was enough sophistication in genetic analysis that one could look for the genetic mutation. But once that sophistication was there, believe it or not, 17 blood samples were sent to the NIH, and the NIH was able to identify the genetic mutation in this family, and the genetic mutation was found in a particular gene, that gene being, and we all read about it in our scientific journals, the gene that has the mutation is called alpha-synuclein. Ever hear that? Alpha-synuclein. Well, neither did we at the time. We said, what the heck is alpha-synuclein? And it turns out it's a protein. We don't know much about what it does, but that's the gene that has a mutation in this family that's clearly causing Parkinson's disease. So think about that for a second. That mutation in that gene is causing Parkinson's disease in this family. What would you do if you were a scientist investigating Parkinson's disease? What would be your next step? Test other people. What about everybody else with Parkinson's disease? So that's exactly what scientists did. And what do you think they found? Nothing. Almost no one has a mutation in that gene. And in fact, there are just a handful of other families that have that genetic mutation. So this is an extremely rare cause of Parkinson's disease. So why are you hearing about it? Why would I even mention it? Well, the next question is, does that genes do what? Genes encode for proteins. Genes tell the body how to make proteins. So what smart investigators did, they said, well, what is this protein doing in the body? We really don't know, but think back. Remember I showed you those Lewy bodies? I said those were clumps of protein. So investigators were able to make antibodies against those proteins, against the alpha-synuclein, and test it in those Lewy bodies. And what did they find? They found that those Lewy bodies are packed with alpha-synuclein. They discovered what are those Lewy bodies. And the answer is those Lewy bodies are packed with alpha-synuclein. And that's not just that family, that's everybody who has Parkinson's disease. So that's a huge clue. Something that's going on in Parkinson's disease is causing abnormal clumping of a particular protein called alpha-synuclein. Big step in understanding what Parkinson's disease is all about and what we need to do to stop or cure it, slow or cure it. Now, another big deal is this. This is a pathologist named Brock, and Brock said, okay, that's interesting. I'm going to go to my lab, and I'm going to take all these brains I have from individuals who died with Parkinson's disease, and I'm going to put them in order from those who have the least amount of alpha-synuclein in the brain to those who have the most alpha-synuclein in the brain to get an idea where did this disease start in their brain and how did it spread. And he saw a pattern. And the pattern that he saw was this clumping of alpha-synuclein started at the bottom of the brain and slowly went up. And it didn't hit the dopamine neurons that live here until what he called stage 3. It also seemed to start right here in the olfactory nerve. Olfactory means smell, so this is the smell nerve, and it came back here. And then over time, the alpha-synuclein clumping came up here to the top of the brain, what we call the cortex, where thinking and memory is. So at the end part of it, it made a lot of sense. The top of the brain is where thinking and memory occurs. And we know 10, 15 years out in Parkinson's disease patients get thinking and memory problems. So that made a lot of sense. Probably takes a long time for this alpha-synuclein clumping to get up there to cause problems. But we're also interested in what's happening way at the beginning of Parkinson's disease, what's happening way down the bottom of the brain, and what's happening in the smell nerve of the brain. Now, think about this. It starts in one area and then it slowly goes up the brain. Well, how does it do that? That's kind of interesting. Well, we sort of stumbled into this with some of the work we were doing. We were interested in the idea if we have a Parkinson's disease patient and we take embryonic or fetal dopamine tissue and implant it in the brains of patients with Parkinson's disease, could those dopamine neurons grow and make connections and replace those that were lost in the brains of Parkinson's disease patients? And we never really showed that it worked well, but we did show that these grafts would persist in Parkinson's disease patients' brains. And we ultimately had 2 patients who lived 14 years after they were transplanted, and the patients eventually passed away. And we examined their brains, and what did we see? Well, we saw that the grafts were still in there, and when they were stained, what happened? This now is the graft. The graft has abnormal clumping of alpha-synuclein. What does that mean? The patient gave the graft Parkinson's disease. Now, these grafts aren't 60 years old and 70 years old. These grafts are 14 years old. How does a graft get Parkinson's disease at 14 years old? And what that says to us, or said to us, was that the Parkinson's disease process is passed along cell to cell. And somehow then it seems to start at the bottom of the brain or maybe in the smell nerve, and it seems to pass from cell to cell, up the brain, up the brain, up the brain, up the brain, and finally up to the top of the brain. Well, that's mighty peculiar. How does it do that? Well, there's been a lot of research about this protein, alpha-synuclein. Well, here's what it looks like when it's functioning properly. It's in this coil that we call a helix, but it's a coil. But this coil can sort of unwind and then rewind, but it spends most of its time in a coil. But sometimes when it uncoils, if it hits one of its neighbor that's also uncoiled, they can sort of stick together in these ribbons, and these ribbons can form sheets. And when these sheets get together, that's when they clump up. And so we think that's the problem in Parkinson's disease, that these coils can start causing the unraveling of neighboring proteins, neighboring alpha-synuclein proteins, and then this process goes from protein to protein to protein, uncoiling, forming a ribbon, forming a sheet, and then clumping up. And we think that's how it may go from cell to cell. And that's illustrated here. Here's one protein uncoiling, inducing this uncoiling in neighbors, and then forming this big clump. And it turns out if you add a clump to a bunch of protein, it causes this clumping formation even more quickly, or causes that clumping to accelerate. So what's happening in Parkinson's disease? It looks like you get propagation, which just means moving along of this abnormal clumping of alpha-synuclein. It looks like that can occur because of mutations in the synuclein gene. Remember the Italian family I showed you? Probably their mutation causes their alpha-synuclein to either uncoil a lot or makes it stickier than normal. There are also some families or individuals who have too many copies of the synuclein gene. So they have too much of that protein floating around. So you can imagine, just imagine all those coils floating around, one unravels. It has a lot of neighbors that it can come into contact with and start clumping up. So some people have too much synuclein. That appears to tend to cause Parkinson's disease. And then from some other families that have mutations, it looks like normally, if you get a little bit of clumping, normal brains have a system to clear out this clumping when it's just a little bit. It looks like some individuals may have a problem with their clearing out system, and if you can't clear out a few clumps, that may allow this problem to cycle out of control. So there's this abnormal clumping. What else? Well, it looks like when you examine the neurons in Parkinson's disease, their energy state is poor. These poor neurons are tired. So maybe this is the problem. Maybe if they get too tired, they can't clear out the clumping, or maybe the clumping is interfering with the energy. I don't know which comes first, which goes second. In addition, you see inflammation around the areas where this is going on. So when we think about how to treat or cure Parkinson's disease, these are the areas that people are working on. How do we prevent this clumping and the spreading of the clumping? How do we improve the energy state of the neurons? And how do we reduce the inflammation? Make sense? All right, here we go. All right. Now, what do we know about patients? And I think you hit on this morning. I said it looks like the alpha-synuclein starts clumping in part in the smell nerve. And we know when a person comes to the doctor and they've got a little bit of slowness, stiffness, tremor, if we test their sense of smell, 90% of patients already have decreased sense of smell. So how many Parkinson's disease patients notice that they have decreased sense of smell? How many Parkinson's disease patients do not notice decreased sense of smell? So about 70% did. So this may be one of the early signs of Parkinson's disease. And remember what I said, we want to identify this disease earlier, because if we can identify it and we have a treatment to slow the progression, that's where we want to head here. What else? Well, we asked ourselves what happens at the bottom of the brain, and the answer is there are some sleep problems that occur. Normally, we dream in what's called rapid eye movement, or REM sleep. That's when we're dreaming. A normal brain has a shut-off switch, so we lie very relaxed, and we don't move around when we dream. But if you lose that shut-off switch, that's REM sleep behavior disorder, and those people act out their dreams. They hit, they kick. And this particular sleep doctor, Schenk, looked at men over age 50 who didn't have any other problems, who had this REM behavior disorder, and what he saw was that over time, 40% when he reported it, but 60% now, went on to develop Parkinson's disease. So this is one of the early signs of Parkinson's disease, and it can also occur after a person has Parkinson's disease. So how many people with Parkinson's disease, or those who sleep with people with Parkinson's disease, believe that they have REM behavior disorder? Hitting, kicking, crying out? Okay, maybe 50%. Okay, so another potential early sign of Parkinson's disease. All right. Now, so far I've just been talking about the brain, but I think you may have heard this morning that this alpha-synuclein clumping is not just in the brain, it's also in the nerves in the body, particularly the nerves that go to the heart and the gut. Things that take care of the automatic systems, which means things you don't need to think about. You don't think about making your heart beat, it just does it automatically. You don't think about making your gut move, it just does it automatically. So here's just an example from a paper that just came out. This is from colon biopsies. People with Parkinson's disease who had colon biopsies, if you use staining for alpha-synuclein, you see that same clumping is going on in the little nerves of the colon. So maybe when you get your colonoscopy at age 50, maybe they should do a little biopsy and look to see if people have this, to identify those who just have the earliest stages of Parkinson's disease. How do I know that that happens early? Well, I don't for sure, but here's something interesting. If you look at people in midlife, if you have less than 1 bowel movement per day, you're about 6 times more likely to go on to get Parkinson's disease later in life, suggesting that even in midlife, maybe it's this alpha-synuclein messing up the nerves to your bowel, causing constipation. Maybe that is happening years or even decades before you get slowness, stiffness, and tremor. What else? If you look at the heart, now in the heart, it doesn't cause heart attacks, it doesn't cause congestive heart failure, but you can see some issues with the heart on special kinds of EKGs and on special kinds of scans. And some of our colleagues, particularly in California, are looking at the idea of using special EKGs again when you go to your primary care doctor to see if they can pick up some of these abnormalities, just to identify people who may have Parkinson's disease even before it gets to the point where you can see slowness, stiffness, tremor. So here's the new look of Parkinson's disease. Premotor, before slowness, stiffness, tremor, early features include decreased sense of smell, that REM behavior disorder where people are hitting and kicking in their sleep, and some heart signs that are very subtle, and then midlife risk factors, constipation, and I didn't mention it, but sleepiness also. So I can imagine a couple things. I already mentioned a colon biopsy at age 50 during your colonoscopy. I mentioned special EKGs. But another thing is when you go to your primary care doctor at age 50, maybe they should do a smell test. And if your sense of smell is down, then maybe they should get that dopamine brain scan to see if you in fact have Parkinson's disease. There are a lot of studies going on looking at markers of Parkinson's disease. We're doing a large one with the Michael J. Fox Foundation right now, and it's trying to do two things, trying to find markers to both diagnose and to evaluate disease progression. We do a lot of studies looking at new medications, trying to see are they slowing the progression of the disease, but it's not easy. Imagine I have a patient with early disease and I put them on a good medication like Cinnamon, all of a sudden they're going from symptoms to very little symptoms. So how do I assess the disease? Just looking at symptoms is complicated. So we'd like to have a body test, a biomarker, maybe a blood test, a urine test, and this study is also looking at spinal fluid from lumbar punctures. And in this study, we're looking at 400 patients as well as 200 healthy controls. We're watching them over 3 to 5 years with at least the first 6 months being untreated, meaning before they go on symptom medication. And so we're looking at all those things, plus smell tests and DAT scans that I mentioned earlier. And so one of the things that's been seen already is that if you look in spinal fluid, this alpha-synuclein is low in patients with Parkinson's disease. Why do you think that would be? Where is it? It's clumping up in the brain. You can't get into the spinal fluid. Spinal fluid's around the brain. Normally it can flow into the spinal fluid, but in Parkinson's disease it's getting stuck in the brain. So that might be an early sign of Parkinson's disease. Okay, so we're looking for early markers. We're looking at ways to identify it even before people get slowness, stiffness, tremor. And if we come up with a good enough way to slow the disease process down, maybe people with Parkinson's disease in the future, it'll never get to slowness, stiffness, and tremor. All right. What about improving motor symptom treatment? Levodopa, or some people might know it as Cinnamon, is still the most effective treatment for motor features, but you know over time people find that the duration of benefit gets shorter and shorter, so they end up taking their levodopa. It takes a while to start working, it lasts a couple hours and wears off. Plus people get a sensitivity to it where they get twisting, turning, called dyskinesia. And both those problems are related to the fact that levodopa only lasts in the blood a couple of hours. So it goes up and down in the blood, and therefore what we want is a nice, smooth levodopa. So companies are working on this in a number of ways. A pump that pumps levodopa right into the gut over time. We'd like to have a nice long-acting oral formulation, and I'll also show you another way to get levodopa into the body as well. So the pump is in investigation. It's actually been available in Europe for over a decade. The pump is about yay big, so the pump right now is still pretty big. The levodopa comes in a cartridge in gel form that's about yay big. So the cartridge attaches to the pump, and then there's a tube that goes through the abdominal wall, through the stomach, and then it goes to where the levodopa is absorbed, right past the stomach, and then the pump can be turned on so it's infusing the levodopa into the gut on a nice smooth basis through the day. And it's very effective in providing good benefit through the day. It reduces off time, meaning time when the medication's worn off, and it reduces the dyskinesia, twisting, turning. There's some presentations this year at our scientific meetings about this, and probably it'll go in front of the FDA late this year. It'll probably be approved next year, and as I said, it's highly effective. The negative is it's a mechanical thing. It's a pump, so it's big to carry around, and it's a tube, so tubes tend to get pulled out, dislocate, they can get clogged up, they can kink, etc. So that's the negative, but for people who are having trouble because their Cinemit's going up and down, this is one alternative that's coming. Okay. Now, something I've been very interested in, what about a long-acting pill? Well, we've been working on this long-acting pill called IPX066, and so far it looks pretty promising. In one of the studies that we worked on and just recently reported, in patients who find that their Cinemit only lasts a couple hours, in this case Cinemit lasting 3 hours, like this dotted line, this medication, the IPX066, a levodopa formulation, seemed to last 5, maybe 5.5 hours or so. So it seems to last significantly longer, and the FDA is looking at this right now. So I think this is going to be an important medication for people who are experiencing fluctuations on regular Cinemit. Now, one of the problems with Cinemit is not only does it just stay in the blood for a short amount of time, but if you try to make a regular slow-release formulation, it doesn't work that well because it's only absorbed in a small part of the bowel just past the stomach. So when it's in the stomach, it doesn't get absorbed. It gets absorbed right after the stomach, but if you have slow release, after it moves past that short amount of bowel, it doesn't get absorbed past there either. So some companies are saying, well, let's attach the levodopa to a different kind of molecule, a molecule that's absorbed all through the bowel. And it turns out you can attach levodopa to a nutritional molecule that can then be absorbed through nutritional absorption points all through the bowel. And this is one of the companies, Xenoport. They have a product, XP21279. And although they just did a study where the medication didn't quite do as well as we all would have liked, there's still reason to hope that this kind of approach has a lot of promise. So I don't think we've really seen the end of it, and I think it makes a lot of sense, and we'll have to see where this goes. Okay, what else? Well, a lot of people are interested in non-dopamine medications, or the ways that we can improve Parkinson's disease without using dopamine. And just to show you this a little bit, in Parkinson's disease, when the dopamine is reduced, you get excess firing of a particular type of neuron here. This is driven by adenosine. So if we reduce the adenosine with what's called an adenosine antagonist, you can reduce that excessive firing and return the system back toward normal. These medications have been shown in patients on Cinemit who are going up and down to reduce the amount of time when patients are off or having slowness and stiffness. So far, they're mild symptom medications, but the promise is that maybe they wouldn't have the same side effects as dopamine medications. So dopamine medications commonly cause sleepiness, they might cause hallucinations, they might cause impulse control disorders. So the hope is maybe these medications wouldn't cause those problems, and these are being tested. It'd be nice to have good anti-dyskinesia medications. These are being tested now in a number of trials. We just recently saw a press release that one anti-dyskinesia medication in an early study seemed to be effective, and we'll see more of these kinds of studies coming up in the future. All right. My favorite topic, slowing disease progression. Here are the medications that are on the list. Rasagiline, brand name is Azilect. Selegiline, brand name is Eldepril. I'm not going to say a lot about the studies that have been done with these. Suffice to say that there's still a lot of interest as to whether these might slow progression. We have not proven that they do. The FDA recently looked at this and said, we agree with Dr. Hauser. No, they didn't say they agree with Dr. Hauser, but they said, no, there's not enough information to conclude that they slow progression of disease, and that may be what you read about. They didn't say they don't slow progression. All they said was there's not enough information to conclude that they do, so that's what they were trying to say. So moving on down the list here. So this gets back to what I spent the first half of this talk talking about. Creatine helps support the energy status of cells. It seems to help protect cells in a number of Parkinson's disease models. It's in a large study. I know at least one person here told me they're in this study. Patients with relatively early Parkinson's disease come into the study. They're randomized to get real creatine or fake creatine for at least 5 years, I think it is. At least 5 years and maybe up to 7 years if I have that correct. And we're going to see how they do long term. And I'm a big advocate of if we want to improve long-term outcome, we got to look long term. If we want to see how people's thinking is long term, we got to look long term. If we want to see how people's balance is long term, we got to look long term. So this is a very large study with over 1,000 patients. It's going to be one of the longest studies ever done in Parkinson's disease. So we're going to learn a lot no matter what creatine does or doesn't do. And we'll find out if creatine improves long-term outcomes. So this is a very exciting study, and we'll see if creatine does or does not help. Now, what else? This is an interesting thing. This is isradipine. Isradipine is a calcium channel blocker, and look at this. Rejuvenation protects neurons in mouse model of Parkinson's disease. This is from a lab of a person named James Surmeyer. And what he found was if you look at juvenile dopamine neurons, let's say in rodents, what happens is they use sodium channels to create the electrical signals of the cell. So a little bit of sodium comes in here, that creates an electrical signal that goes down the dopamine cell and causes the cell to release dopamine. And everything works great. Sodium channels are used for pacemaking, juvenile dopamine neuron. But what happens is, as time goes on and the juvenile dopamine neuron grows up, these sodium channels are replaced by calcium channels. So now a little bit of calcium comes in here. That causes the electrical signal that goes down the neuron to release dopamine. The problem is when calcium comes into the cell, it does bad things and interrupts the energy-producing status of the cell, these mitochondria, which are responsible to make energy. So now when the energy status of the cell goes down, they're not as strong. They can't fight off insults as well, so these cells are weak. And Dr. Surmeyer thinks in part it's because they use these calcium channels. So he said, what happens if you block calcium channels? Does it kill them? Does it make them weaker, or what? And what he found in his mouse model was that if you block the calcium channel, these juvenile sodium channels come back and they take over the pacemaking function once again. So the cells don't die, the sodium channels come back, they start making electrical signal to release dopamine, and now the energy status of the cells improved, they're stronger, and they are able to fight off insults or toxins better. So the question is, will that work in patients? Well, I don't know, but we're doing a number of trials in patients with a calcium channel blocker called isradipine to try and determine that. Now, we're just at the beginning, but we shall see over time. Make sense? A little bit. All right, another medication that's being studied is pioglitazone. This is a medication that's out there used to treat diabetes. Pioglitazone in models of Parkinson's disease reduces inflammation. And I didn't tell you yet, if you give a certain chemical called MPTP, whether it's in rodents or monkeys, it kills dopamine neurons. And when the dopamine neurons are dying, you also get inflammation. So in this particular kind of study, they took monkeys, they gave them MPTP, you see loss of dopamine neurons, you see inflammation, and then right after the MPTP, actually a day later, they treat the monkeys with pioglitazone or placebo, which means a fake, and what they saw was that the monkeys treated with pioglitazone recovered better, meaning their function recovered better, and there was less inflammation and better recovery of the neurons. So this too is now being studied in patients. All right. What else? Cogain. Cogain in study is called PYM 5028 or 50,028 really. And cogain, what it does is it increases neurotrophic factors. Neurotrophic factors are also known as growth factors. Growth factors in the lab look great to make dopamine neurons grow nice and big and strong and fight off insults and toxins. The problem is they're very hard to get into the brain. So this is a different approach. This is a factor that gets into the brain and causes the brain to increase its production of these growth factors called GDNF and BDNF. So in this model, a mouse, it's given MPTP, which kills dopamine neurons, and then it's given this medication, PMY 50,028, and what happens is this growth factor, BDNF, is increased 500%, the growth factor GDNF is increased 300%, so a very striking effect in this mouse model, and it basically, if I can hit my button here, basically saved almost all the dopamine neurons. So this is a very exciting in the mouse, and that's being studied in patients right now. In fact, that study I just saw is going to be filled up tomorrow. We'll follow those patients through 6 months, and we'll see how they do. All right, other symptoms that are being studied. Droxidopa is a medication that's available currently in Japan to treat some symptoms of Parkinson's disease. Unlike treatment of dopamine, this medication increases a different chemical called norepinephrine. Not only is dopamine low in Parkinson's disease, so is norepinephrine. What that means is that it relates to certain other symptoms, particularly falling blood pressure. So some people with Parkinson's disease, when they get up, their blood pressure falls. This looks like it might be a good treatment for that. Interestingly, as we've studied it, it looks like it might also reduce falls. It might also reduce freezing, that is, feet getting stuck. So all of that is being studied with droxidopa. ACP-103, it's under investigation to see whether it reduces hallucinations. And then I'm going to mention 2 other trials, and then I'm going to do the finale here. Rotigotine patch. How many people were on rotigotine or Nupro patch in the past? Okay, this is a dopamine agonist. It's a medication. It looks like dopamine. It comes as a patch. It's been off the market for a couple of years just because it was sort of sticking to the patch, let's say. So the company had to reformulate it. It's coming back soon, probably in the next couple of months. But one of the things that was very interesting about it is that I think it improved patients' apathy, motivation, mood, and fatigue. So we're designing trials right now to look at this. So that's going to be very interesting. In addition, with regard to Azilect, also known as rasagiline, we're designing trials to evaluate whether it improves thinking and memory. And so that brings me to the grand finale, the latest and the greatest. And here we go. So this is where I think the field is headed, and this is really, I think, an amazing story. And I told you a lot about how in Parkinson's disease, I think the critical thing is this clumping of alpha-synuclein. And although I don't know exactly how it causes problems, I think it is at the heart of Parkinson's disease. And this is from our friend Jeff Bronstein at UCLA, and he developed a molecular tweezer, and you can see it inhibits alpha-synuclein toxicity. So imagine, what would a molecule that's a tweezer look like? Well, let me show you. There it is on the left. There's a molecule that he and his lab designed, and look at this one on the left, CLR01. And what he showed was if you take cells in a culture dish and add a whole bunch of alpha-synuclein, the alpha-synuclein clumps up in the cells and kills them, and here you see the survival of the cells is very low. But if you start adding this molecular tweezer, you start improving the cell survival. And he showed then that this molecular tweezer inhibits the clumping of alpha-synuclein, and in a little different experiment, he actually showed that even when you have clumping, it declumps the alpha-synuclein. So pretty amazing. And the very last part, who knows what these are, other than Dr. Sanchez-Ramos? What? Zebrafish. Very good. Zebrafish. That's right. So zebrafish are now commonly used in the lab for various experiments, especially genetic experiments. And what was done in that lab was that they genetically engineered zebrafish to overproduce alpha-synuclein. So alpha-synuclein would clump up, and many of these zebrafish would not survive. And of those that did survive, many would have abnormally formed tails. And then to do this experiment, then what they would do is add this molecular tweezer to the water in which these fish would swim and drink from. And here's what was found. If just look at this first one here, he found that normally just the regular engineered zebrafish that make alpha-synuclein, only 30% survived, and only about 5% had normal tails. As they added some of this molecular tweezer, the survival rate went up. I think it's 35% here. Many more normal tails. Add a little bit more of the molecular tweezer, survival rate's up to 45%, and now you've got about 30% normal tails. So a very clear effect, and it's an effect on the clumping of alpha-synuclein. So I think this is really the steps down the road toward a cure, preventing alpha-synuclein clumping, preventing the toxicity of alpha-synuclein. All right, so I told you a lot about research. This is the way we develop better treatments. This is the way we will get to a cure. If you have the opportunity to participate in research, please, please, please consider it. It's basically a very altruistic thing to get involved, but also I always say we have the treatments we have today because people before us, patients and doctors before us, did it. If nobody ever does it and everybody just says, call me when you got the cure, call me when you have a better treatment, we won't ever have a better treatment. And in addition, I like to tell people, when we have something, we need to evaluate it, and even if it turns out negative, that's good, because then we can push it aside and move on to the next thing and see if we can find something better. So try to get involved, try to get others involved. If you find a friend or family member is newly diagnosed, that's where the most research goes on, right at the beginning of Parkinson's disease. Try and get them involved. In addition, as I mentioned, there's some studies that are for healthy controls. So if you don't have Parkinson's disease, there's still ways you can get involved in research. So with that, thank you very much.